I'm going to invite Dr. Shweta for her talk. And she's a wonderful speaker. She's a very good surgeon, and she's a RIO alumni, RIO Chennai. Thank you, Shweta, for being.
Thank you, Dr. Mamta, for including me in this instruction course, and I thank the AIOC Scientific Committee for the opportunity. So I'll be talking about managing acute congestive glaucoma today. So each of us here has about 10 minutes to talk about these ophthalmic emergencies. Hopefully, when such a patient walks into your OPD, you will be able to act within 10 minutes and manage them well. So acute angle closure glaucoma, as we all know, it's a potentially blinding ophthalmic emergency caused due to extreme increase in intraocular pressure due to a relatively sudden blockage of the trabecular meshwork. But before we dive into managing acute angle closure glaucoma, let's quickly recap the natural history and staging of angle closure glaucoma. So in primary angle closure suspect patients, there is iridotrabecular contact of more than 6 clock hours, but usually the intraocular pressure is normal. In primary angle closure, you have more than 180 degrees of iridotrabecular contact along with elevated intraocular pressure and peripheral anterior synechia. And when you have primary angle closure glaucoma, you have all of these features. Additionally, there is optic nerve damage as evidenced by perimetric changes and thinning of the retinal nerve fiber layers. We are going to be talking about acute angle closure crisis, which is a very sudden event, but there are some predisposing factors. So angle closure glaucoma, as we all know, is more common in Asian population, a little more common in females. Elderly patients with hypermetropia. Family history, if there is a family history in a first-degree relative, the patient is at increased risk. Then certain ocular biometric factors like shallow anterior chamber, short axial length, increased anterior curvature of the crystalline lens, a thick bunched up iris. These are some of the risk factors. Then certain topical and systemic medications which dilate the pupil or cause anterior rotation of the ciliary body in at-risk patients is something we need to keep in mind as well. And then stressful events or prolonged exposure to dim illumination is what can precipitate an attack of acute angle closure. So before we move on to how the patient presents, this is something important to remember. There are a lot of drugs that can cause acute angle closure, but the two very common and very important ones to remember are topiramate, which is an anti-epileptic drug used in the treatment of migraines, and escitalopram. It's a very commonly used antidepressant drug, goes by the tablet Nexito, and it's a selective serotonin reuptake inhibitor, and has been known to cause acute angle closure glaucoma. So just the common drugs should be kept in mind when you're seeing a patient with acute congestive glaucoma. Now, when this patient comes and sits in front of you in front of the slit lamp, the first thing you need to think about is what is causing this angle closure. So what is the mechanism of angle closure? Now, there are potentially 4 levels at which this can happen. One is at the level of the pupil, which is the most common, pupillary block glaucoma. Then the other thing could be at the level of the ciliary body, maybe due to a plateau iris, or if the peripheral iris is bunched up or iris crowding. So then it can happen at the level of the lens because of a phacomorphic glaucoma or a microspherophakia or a subluxated lens. And then at times the cause can be retrolenticular, as in malignant glaucoma or a supraciliary effusion or a massive vitreous hemorrhage too. So like I said, it's very important to quickly determine what is causing this angle closure in this particular patient sitting in front of you. And why that is important is because pupil block mechanisms respond well to treatment with pilocarpine, but the same pilocarpine can spell trouble when you use it in lenticular and retrolenticular causes. So for the posterior mechanisms, you have to use a cycloplegic agent like atropine or cyclopentolate. So this is something, I cannot overemphasize the importance of this point. So the patients typically present with blurred vision, rainbow halos around lights, pain, redness, headache, nausea, and vomiting. And the diagnosis of acute congestive glaucoma is largely clinical. Intraocular pressures are extremely high, usually more than 35 millimeters of mercury. There's circumcorneal congestion, corneal edema. There's a shallow or a flat anterior chamber. More often than not, we do see some anterior chamber reaction as well. Closed angles on gonioscopy. There's usually a mid-dilated, sluggish pupil. And you may end up seeing some signs of previous angle closure attack, maybe like peripheral anterior synechiae, some iris atrophy, glaucoma flecken, posterior synechiae, or irregular pupil. And if corneal edema is not too bad and visualization permits, you will be able to see a hyperemic optic disc in acute cases. Now, gonioscopy is diagnostic. You will see the extent of angle closure, presence of anterior synechiae on gonioscopy, but sometimes corneal edema may preclude proper visualization. So, this is a quick, simple test on the slit lamp, the peripheral anterior chamber depth. You can grade the shallowness using the Van Herrick's grading, wherein you use a very narrow slit of the slit lamp, project it at the limbus at about 60 degrees, and compare the thickness of the cornea with the dark area that you see in the anterior chamber. So, stream plug imaging can also prove useful sometimes when corneal edema is very severe and you're not able to do any sort of grading on the slit lamp. And if you have access, there are certain diagnostic modalities like anterior segment OCT and ultrasound biomicroscopy. So whenever there's a doubt about the mechanism of glaucoma, you may use these to rule out secondary causes like maybe a plateau iris or uveal tumors or malignant glaucoma. So what are the principles of management? First and foremost, we make the patient comfortable, relieve headache and nausea. The next thing is to lower the intraocular pressure immediately, then to rule out secondary causes of angle closure, and to relieve the pupillary block. So what are the immediate steps? So first and foremost, give the patient some analgesic and antiemetic if there's nausea and vomiting. Start the patient immediately on acetazolamide, 500 milligram orally if there's no vomiting, or intravenous mannitol, 20%, 1 to 2 gram per kg over 1 hour. Or the other commonly used drugs are 50% glycerol or oral isosorbide. Now, we need to be very careful about contraindications to these drugs, which I'll talk about briefly. So once you've given some sort of systemic medication, these are hyperosmotic agents, then you also add topical aqueous suppressants. You can start the patient on timolol or brimonidine or dorzolamide eye drops. And more often than not, there is some anterior chamber reaction. So you are advised to start prednisolone or dexamethasone eye drops, QID. So a few things to keep in mind. If the patient is allergic to sulfonamides, has impaired renal function, then you are better off holding off acetazolamide. Acetazolamide also causes a few common side effects: paresthesias, polyuria, and fatigue. Mannitol is contraindicated in patients with renal disease, congestive heart failure, and pulmonary edema. Glycerol is contraindicated in diabetics. And topical beta blockers are better avoided in patients with asthma. And alpha agonists are avoided in patients with coronary artery disease. So once you have taken these measures to lower the intraocular pressure, maybe you can reassess the patient after 30 to 60 minutes and then start the patient on pilocarpine eye drops. This is a miotic eye drop. And sometimes when we all know that when the intraocular pressure is very high and if there is sphincter ischemia, pilocarpine doesn't act very well. So which is why lowering intraocular pressure is the more priority step, right? So once you've started the patient on pilocarpine, you can instill the drops every 15 minutes, thrice, and keep up with the timolol or brimonidine eye drops, with the topical steroids. And then you can step down the oral acetazolamide, make it probably 250 milligrams TDS or QID. The most definitive way to relieve the pupillary block is a laser peripheral iridotomy. Now, sometimes the corneal edema can preclude your visualization. In that case, you can use topical hypertonic saline and 50% glycerol to sort of decongest the cornea. And then you have to get ahead and go ahead with a Nd:YAG laser peripheral iridotomy. So typically 5 millijoules, 4 to 8 shots, choose a superior location and make sure that the size is at least 200 microns. Now, laser peripheral iridotomies can get occluded within the first few days after the iridotomy because of pigment block or tissue debris. So which is why you should ensure that the minimum size is at least 200 microns. All right. If that doesn't give you an adequate IOP control, you can go ahead and do a laser peripheral iridoplasty using argon laser. Now, what this iridoplasty does is it sort of retracts the iris tissue and opens up the angle. This doesn't seem to provide long-term IOP control, but as a short-term measure, if LPI fails, you can go ahead and do a peripheral iridoplasty. If this doesn't work, you have no choice but to go in for a surgical iridectomy. And what is must is doing a prophylactic laser peripheral iridotomy in the fellow eye. So here is a quick reference flow chart for the management of acute angle closure glaucoma. So it's a stepwise approach. We start off with analgesia and antiemetics. Then we examine to measure the IOP and identify or exclude secondary causes. Then we identify allergies and contraindications because we're going to use drugs to lower the intraocular pressure. So we need to know the renal status of the patient, whether there's any congestive heart failure, any coronary artery disease. And while you're at it, also quickly ask for drug history of, say, topiramate or escitalopram. The next step is to start either your intravenous mannitol or acetazolamide, topical aqueous suppressants, and pilocarpine eye drops. Review maybe about after an hour, and then definite laser peripheral iridotomy in both eyes. After the iridotomy, add steroid eye drops hourly for the day, and then 4 times a day for 1 week. After a couple of hours, please reassess the response, and then if it is IOP control is not adequate, consider a peripheral laser iridoplasty. Once you settle the patient, if there are any secondary causes, we need to treat the primary pathology. And one important thing to remember is lenticular and retrolenticular causes have to be treated with atropine and not pilocarpine. And I'll just sum up. Follow-up is extremely important. Sometimes in emergencies, we manage the acute condition and then, we have to tell the patient follow-up is extremely important. So I would generally follow up on day 1, day 3, day 7. And then, investigate. We have to look for the LPI patency and repeat the iridotomy if it doesn't open up after the first 1 week. And then, of course, assess the perimetry and do an RNFL thickness analysis. And based on the pressure control, adjust medications if required.